hip, imaging of the hip. This is the conventional X-ray for a normal hip, showing the soft tissues of the buttocks, soft tissue of the belly, urinary bladder, fat planes of the peritoneum, parietes, and some gas within the sigmoid and rectum, some gas in the region of the cecum, some gas in the left side of the colon, and the hip joints, pubic rami, superior and inferior, symphysis pubis, neck shaft angle, joint space, joint configuration, and joint margins, and joint width. And here there are some sclerosis denoting some lumbar spondylosis. Here the frog leg position done in case when we study the femoral capital epiphyses, whether dislocated or subluxated or congenital dislocation. And here is the oblique for the iliac crest on tangential, and to see the neck shaft angle on its entirety. This is the pelvis, what we call outlet view, and here is the pelvis, an inlet view. Of course, this will show the outline and elucidate any deformities along the outline. This is the sacrum lateral, sacral concavity, lumbosacral junction, iliac crest, both femora. This is the right proximal femur, and this is the proximal femur oblique. Of course, the change of position allows for better study of the femoral neck. Here CT for the region of the pelvis, promontory, mottling within the sigmoid, small intestinal loops, the iliopsoas muscle, the rectus muscle, minimus, medius, and maximus glutei, as well as the vessels here and there. This is the level of the acetabulum when we get the anterior acetabular mass with the anterior acetabular rim, posterior acetabular corner or mass with the posterior rim, the head of the femur and the fossa navicularis, urinary bladder, seminal vesicles, rectum, rectus, and again, this is the region of the iliopsoas, and we have the obturator internus as well as the obturator externus. In this we can, this one we show the yes, we'll show number 15, which is obturator internus, and number 19, which is obturator externus, internus and externus muscles. The protocol in MRI is to do axial scout, then coronal T1, coronal stir, axial proton density and axial T2, sagittal T1 or T2 for the diseased hip. Axial scout, coronal T1 and stir, axial T2 and proton density, sagittal T1 or T2 for the diseased hip accordingly, or both. We search for alignment, we search for the articular surfaces, space, and surrounding soft tissue. So the alignment, the articular surfaces, and space with the soft tissues surrounding. This one, of course, is the obturator. This one with this facial plane is the glutei, and this is the iliopsoas muscle. So we can see the surrounding muscles because of the surrounding bed of fat. Again, obturator, glutei, and iliopsoas muscles. Here, this is the iliopubic bone or junction, and this is the ilioischial junction, and this is the teardrop. This is this line is representing the iliopubic, and this line is the acetabulum with the acetabular fossa. So we have iliopubic line and ilioischial line. Sacroiliac joint has two components, one belonging to the sacrum and one belonging to the iliac bone. Both are overlapping in this area. This is what we call center edge angle. It's a vertical line passing in the center of the head with another line passing at the outer margin of the acetabulum here, the edge. Normally it is about 20-25. If this is less than that, that means that this one is slanting up, and if slanting, the angle will be more close. That means shallow acetabulum or dysplasia. So if it is decreased, this center edge angle, vertical line passing in the center and another line passing at the edge, this should be not less than 25. If less, this may indicate shallow acetabulum and dysplasia. Here are some normal lucencies. Of course, we said that this is the ischial-iliac line, that one and that one. This is part of the head, this is part of the neck, and this is part of the supraacetabular iliac bone. Sometimes you get such an appearance. It's called herniation pit. It appears like that in the MRI, and it may show like an erosion. This is called herniation pit, and it is of no significance. sometimes you can see the trabecular bones, and this indicates osteoporosis. That means that the fine trabeculae disappeared, only the coarse trabeculae are there, and this is called trabecular bars. If you have this coarse trabeculation or this coarse trabeculation, think that there is osteoporosis of the surrounding bone, and these are the main fiber, the main trabeculae still there to carry the weight. The common pathology is congenital hip dislocation, trauma, inflammation, degeneration, avascular necrosis, and Behçet's disease, of course, and miscellaneous conditions like slipped femoral epiphysis, synovial osteochondromatosis, femoral neck anteversion, transit osteoporosis. Of course, if we apply here the arthritis group we have just mentioned in the presentation for arthritis, you can say that there is hypertrophic arthritis, degenerative. You can say that there is infective arthritis, whether biogenic or septic, or granulomatous like TB and fungus. And we can put all the connective tissue diseases, including the lupus and allied conditions. Ankylosing spondylitis should be also considered. But the common pathology are these group: the congenital hip dislocation, trauma, inflammation, degeneration, avascular necrosis and Behçet's disease, and miscellaneous conditions as osteoporosis and slipped femoral epiphysis and chondromatosis and femoral neck anteversion. In the trauma lesions, we might get muscle sprain, starting by muscle edema, or disruption or complete tear. Disruption or laceration, you will find blood. The word laceration or disruption are the same. It means blood at the site of the tear, and complete muscle tear means retraction and ends by atrophy. So again, traumatic lesions in the muscle could be muscle edema, could be laceration or disruption, and complete tear, lastly resulting in retraction and atrophy. This is showing some edema, muscle sprains of the obturator externus and the adductor brevis, showing edema in the T2 weighted images. That means this is muscle sprain. The second one is the disruption or laceration, and here the region of the hematoma of the semitendinous muscle. And lastly, grade 3, it means that there is interruption, and the interruption of the rectus femoris muscle with atrophy compared to the left side. If you see here this region compared to this one, definitely there is atrophy under it due to retraction and tear. Here it is, this scene, grade 3 tear of the rectus femoris with atrophy compared to the left side. Now here the acetabular fracture involving the rim and the posterior corner or the posterior mass and its rim. Acetabular fracture. Acetabular fracture without displacement. Acetabular fracture interrupting the teardrop. Stress fracture of the femoral neck seen in osteomalacia, usually bilateral. Stress fracture. Femoral neck fracture complicated with avascular necrosis. Here it is a fractured neck, and here are the heterogeneous density, minimal sclerosis starting, then the apparent separation, but the true separation is not yet, there is no true separation yet. Still there is continuation here, so there is an attempt of separation. This is avascular necrosis. Here is fracture superior ramus. Here is another stress fracture of the neck. Insufficiency fracture in osteoporosis. Here it is. Insufficiency fracture in osteoporosis. See the only some coarse trabeculation are still seen, but the fine trabeculae are absorbed, and we have the stress fracture or insufficiency fracture. Although the word stress is usually kept for stress means some effort done on the bone or pressure on the bone, while insufficiency fractures occur spontaneously, yet the terms can be used instead of each other. Here we have a avulsion fracture of the anterior superior iliac spine, and here we have avulsion of the symphysis due to adductor injury. Beforehand, we were using MRI arthrography for visualization of the labrum tear. MRI can show this without injection. Septic joint bulging fat planes, if there is inflammatory process in this joint, we can find any bulge of the soft tissue, whether of the medial side of the capsule or outer side of the capsule. This means that the fat beds or the fat planes will be bulging, and indicates that there is accumulation of fluid within the joint capsule. Transient osteoporosis is something of unknown etiology. Male is affected, usually unilateral. It resolves spontaneously in 6 months, and it will present with pain but no history of trauma. Transient osteoporosis is usually seen as decreased density. Transient osteoporosis is hot because of hyperemia. Transient osteoporosis is edematous bone. This is in T1 and this is in T2, just edema of the bone. Transient osteoporosis is again bone edema. So it is hyperemic. That's why it appears hot in isotope study, and it is porotic because it is hyperemic, and it is edematous as seen in MRI because again it is hyperemic, just hyperemia. and then spontaneously it recovers. Here you find definite change in T2, in T1 and T2, edema of the bone, and here is the heterogeneity and osteoporosis. Avascular necrosis could be due to trauma, corticosteroids, sickle cell anemia, alcoholism, Gaucher, radiation, collagen, pancreatitis, a lot of things. Avascular necrosis usually comes with corticosteroids and sickle cell anemia, and avascular necrosis is heterogeneous femoral head, mixed sclerosis and porosis. Sclerosis means the dead parts. Here is the separate fragment, but to have this separate fragment we have some stages: a stage of heterogeneity, stage of attempt to separation, state of complete separation and acting as a loose body within the joint. Avascular necrosis here is seen as heterogeneous hypertensity, sclerosis of the bone on both sides, sclerosis of the bone on both sides. Usually such things are due to systemic disease or corticosteroids. In stage 1 here we can find that the the fat plane starts to disappear and sclerosis start to appear. In stage 2, this localization of sclerosis, and as if there is a fragment wants to separate but not yet separate. This is stage 2. In stage 3, in stage 2 again, still the fragment is there and there is a line of cleavage but no separation. In stage 3, the separation occur and the line of cleavage is well seen. And in stage 3 here we have the fragment. There is fragmentation, part of the bone is lost, and here the head is seen compressed, flattened, fragmented, and may show loose bony bodies. Here it is, well defined line of cleavage, separate fragment. This one is separate fragments. In stage 4 we have the full-blown picture of the avascular necrosis, the flattened, fragmented, condensed, deformed head with loose bodies. Now this is the start, central necrosis because of a subcapital fracture. There is some sclerosis here, central sclerosis, I mean central sclerosis. Sclerosis means death of bone due to fracture at the subcapital region. Here the sclerosis is more and foci of destruction are seen. Burst disease is something similar but occurring in young. It's avascular necrosis of the femoral capital epiphysis. There is no etiology, and boys again are more than girls. In Burst disease we have, this is the end result. We have stages again. In Burst disease the head is not united, so expect that the part of the head involved is all the femoral capital epiphysis. The anterior part of the epiphysis can start with changes if there is metaphyseal sclerosis. If there is metaphyseal sclerosis and if all of them, it will be 3, and the last is flattening. If we say that start sclerosis, start condensation, start flattening, followed by flattening, these are the stages of persistent disease. Sclerosis, fragmentation, and flattening are the stages of persistent disease. Here, if we say that there is sclerosis, then fragmentation, and then flattening. Of course, this is healed, but there is residual metaphyseal changes, and there is flattening of the femoral capital epiphysis. So sclerosis and fragmentations, and then healing by flattening. Sclerosis, fragmentation, and flattening. We can say that this is fragmentation, and then here starts to collect, to heal, and this is the healing with flattening and collapse of the femoral head. In slipped femoral capital epiphysis, we get posterior inferior displacement of the proximal femoral epiphysis. This is epiphysis, it becomes posteriorly displaced and at the same time inferiorly displaced. Thus results in this triangular piece of bone, usually following trauma. It's bilateral in most of cases, in quarter of cases, and there is associated, expectedly, you can see avascular necrosis in some, because there is interruption of the vascular supply of the femoral head. Slipped femoral capital epiphysis. Here, displacement of the femoral capital epiphysis down and posterior, and this one is showing coxa valga deformity. Now come to osteoarthritis. We have the famous narrowing, the famous osteophytic clipping, subchondral sclerosis, pseudocysts, effusion, sometimes air formation, and the superolateral migration of the femur. Here are the sclerosis, the pseudocyst formation, the migration of the femoral head. This is osteoarthritis. Osteoarthritis is irregular outline, sclerosis of the opposing margins, some narrowing of the superolateral aspect of the joint, pseudocyst formation, osteoarthritis. Osteoarthritis, pseudocyst formation, narrowing of the superolateral part of the joint, pseudocysts here and there, marginal lipping here and there. This is the appearance of the and the sclerosis of the opposing parts of the bone. This is osteoarthritis. Combined avascular necrosis and osteoarthritis. Flattened head, collapsed with pseudocystic changes, sclerosed margins. As we said, that these are the stigmata of the osteoarthritis. Pseudocyst formation and relative narrowing of the superolateral aspect of the joint with sclerosed margins. These are osteoarthritis. Of course you can identify the line of cleavage here, denoting that there is avascular necrosis. And we said that an avascular necrosis, we can see heterogeneity, and then we can see attempt at separation, and then complete cleavage, and then separation of the fragment. While in the Perthes disease, the process involves the whole epiphysis. There is epiphyseal plate, so the whole epiphysis is involved in heterogeneity, fragmentation, condensation, and the healing is the collapsed head. Spondyloarthropathy, we have here left erosive changes. Still there is only one margin is seen, and the right side is sclerotic, and this denotes that there is asymmetry of involvement. Asymmetric involvement occur in psoriasis usually, while in ankylosing spondylosis the earliest sign in sacroiliac joints is the widening, and this widening soon start erosions like this, ankylosing spondylitis, erosions of the sacroiliac joints, and then we can get lastly in this one the ankylosis will ensue. There will be ankylosis. So widening first, erosion second, and then obliteration. This is ankylosing spondylitis of the sacroiliac joints. Asymmetry suggests psoriasis. Bilaterality and symmetry suggest ankylosing spondylitis. Protrusoacetabular or the medial migration of the femoral head suggests rheumatoid. Of course, it's associated with osteoarthritis and osteophyte formation. Here is a typical example of the protrusoacetabular of rheumatoid. Here are the subcutaneous synovial collections of rheumatoid. Complex cystic synovial fluid decompressing into the iliopsoas fossa, rheumatoid. In osteochondromatosis, you will find multiple loose bodies within a large synovial cavity. Multiple calcific loose bodies within large synovial cavity starts either as cartilage or fragments, which soon calcifies and form this osteochondromatosis. Synovial osteochondromatosis is seen in MRI as low intensity. Here we have a destructive process along the neck of the femur. Destructive process which is mainly medullary. The cortex is thinned out, and this is because still there are tensile fibers getting the body weight here, compensating for this weakness. Round cell tumors can do like this, can do these erosions, these lytic permeating lesions. Of course, if you find the iliac bone involved in such a process, you are confronted with some differential. In the young, it could be an Ewing. In the old, it could be a chondrosarcoma with these flaky or irregular calcifications within the soft tissue. And of course, you should include metastasis for the adult uh, neuro neuroblastoma. Yes, neuroblastoma deposits in baby in children. Avulsed lesser trochanter here is pathologic usually, and it can indicate a deposit. Osteoid osteoma can be seen, and intense periosteal reaction here and there can be identified. This is the calcific nidus surrounded with the soft tissue osteoid, and then the bone reaction. In hip dysplasia, the central or the center edge angle is less than 25. If you make a line starting from here and is vertical, and a line drawn like that, so the angle between this one and that one is less than 25. This is due to shallow acetabulum or slanting acetabulum. Here it is. A vertical line from the center of the head up, and a line from the edge to intersect with this one. It will make a small angle. Here is the hip dysplasia appearance with the shallow acetabulum. Center edge angle less than 25. If you compare left with right, you'll find the slanting or the shallow left acetabular roof with the definite displacement of the femoral bone, and the femoral capital epiphysis is articulating now with the iliac bone itself with pseudo arthrosis. There is here developmental deformity of the femoral bone, or what we called short femur. You can call it short femur. And here you can get the famous coxavara deformity with the inferior displacement of the femoral capital epiphysis and the triangular piece of bone that is slipped femoral epiphysis. Femoral neck anteversion is the line drawn along the axis of the femur, and the line drawn along the axis of the femoral neck. Here is the distal, and here is the neck of the femur. In the neck of the femur there is a line here, it can be drawn like that, and a line here as getting the axis, and these are the measurements. Should not be more than 8 to 10 after 20. Here is the line, and here is the other line. the measurements of the angle made of both these two lines will be any of this according to the edge, and this is called the femoral neck anteversion. Here it is. This is the femoral neck axis and the femoral distal axis, and this show the the angle. What is this? Extractive process involving the right iliac bone and acetabulum with calcifications of the flaky type, ring type, linear curved type, mottling type. That means it's a chondrogenic tumor, and being involving soft tissue, it is malignant with central dislocation of the hip. This is chondrosarcoma. Here we can get an area of osteolysis seen here with no matrix calcification. This could be a deposit, and here we will get the swollen pubic ramus with fluid level, that means aneurysmal bone cyst, and this is multiple deposits. This is osteomalacia with a triangular shaped pelvis and multiple stress fractures here and there, bilateral, almost symmetrical, and you can see the stress fractures are involving the supraacetabular regions. Osteomalacia, usually of chronic renal failure, and this one is involving the region of the sacrum. It's a soft tissue tumor involving the sacrum. This is chordoma, and here is bilateral involvement of the sacroiliac joints. It is usually with erosions, usually seen in ankylosing spondylitis. Thank you.